89.9 Qute-FM. Oh, that is the jam, man. Hey, so listen, I told you she was coming in, and she's joining me in the air chair. I've got Dr. Z, or Dr. Zarfos, joining me. And so, you know, we've been having this conversation all month long, and it's a very important conversation. You know the statistics, and we're going to talk about some of those statistics. But first, Dr. Z, let me welcome you to the air chair.
Thank you. I'm honored to be here.
And I am so happy to have you because now you're not new to the Hartford area.
No, I worked at St. Francis Hospital for part of my career and out in Plainville.
All right. And you know a lot about the girls, and we've been talking about the girls. The
Yes.
tots, if you will, is what my mom used to call them. But more importantly, the statistics are pretty serious.
Yes.
You know, I told you we have a large African-American listening audience, and as we're talking about women of African descent, we've been talking about the statistics as it relates to just cancer overall, breast cancer. 1 in 8 women will be afflicted with this disease. And it's my understanding African-American women get cancer less than white women, but we're more likely to die from the cancer.
That's exactly right. And that can be a frightening statistic that can make us shy away from mammograms and that sort of thing, but it should be the opposite. We
Yes.
need to empower women to understand. So the example I like to use is when people have diabetes, they know they have to check their eyes and their blood pressure and their toes. So if we know what our health issues are, we
Yes.
are equipped with the facts to take care of ourselves. And Joyce, you're absolutely right. 35% of African American women develop breast cancer under the age of 50, as compared to 22% of Caucasian women. So there's a higher proportion of young women. Now think about those years in your life. What are more important years when from 20 to 50? You're raising your family, you're getting your education, maybe going back to school, maybe you're the sole breadwinner. You're in the peak of building your career.
You're in the prime of your life at
That's
that
right.
time.
It's
Yeah.
a very important time. And so, well, we're all busy. We're too busy to check our breasts or go to the doctor or get our mammogram or whatever. And this is an important time. We need to let women know we have to take care of ourselves.
And at that, particularly at that age too, sometimes we're caregivers. We're taking care of not only our kids, we're taking care of our parents, and we're not slowing down sometime to take care of ourselves.
That's right.
And so now you know a lot about this, and I know we jumped right into talking about breast cancer, but just give a little background about yourself and your knowledge on this issue.
Well, as I was telling you, I started out as a general and vascular surgeon in Middletown, Connecticut. And then after 11 years there, moved to Yukon, worked with a really good breast surgeon there, Dr. Peter Deckers, and then went over to St. Francis, where I was the director of the breast center. Now, St. Francis is a wonderful place because at that time, in 2005, it was the only place in the state where you could have your mammogram and have a breast exam on the same day.
Okay.
And receive the answer and report on your mammogram at that same time.
So no waiting, no getting that letter in the mail kind of thing.
Absolutely. And St. Francis is still the centerpiece of that. After that, I went out to Plainville. There's a cancer center that Hartford Healthcare built, and we brought that service to patients in that area because it's exciting for me to have that service developed and delivered to more and more women across the state. And now I'm back at Middlesex Hospital where I started, and we've just opened a breast comprehensive health center, and we're offering the same service where you can have your mammogram for a certain number of patients, have your report the same day, and see your surgeon the same day.
And how important is that?
Oh, I think it's important because it's called peace of mind.
Yeah.
You know, some women will hold off getting their mammogram because of fear of the unknown, but also the pauses, the waiting in between having your mammogram, getting the report, maybe have to have extra views. It's that uncertainty that's scary.
And, you know, and that happens, all right? So if I talk about me, for example, I do my mammogram. I'm always on it. But then I get this report where they say, particularly African-American women or women of African descent, we have what you call dense breasts.
Yes.
And so they may invite you back. What exactly does that mean, Dr. Z?
Well, I think this is a great question because there's data now that does look at actually African-American women have a higher incidence of dense breasts, not just cancer in younger women. So I want you to think of your mammogram as a picture of your breast, okay? And if you have dense breasts, which means your breasts are most fibrous, more fibrous, and when you're young, your breasts are fibrous.
Okay.
It'll look like a snowstorm on a mammogram, okay? It'll look white. Now, cancers look white. So if your breasts are dense, cancers can be hidden or shadowed in there. So the good news about Connecticut is in 2009 it started a role that went across the country, legislation that insurance companies have to pay for screening ultrasounds if you have dense breasts, and ultrasounds can see through that snowstorm, can see through that white dense breast and find cancers.
So don't go stir crazy when you get that letter saying you got dense breasts.
Yes.
To come back and continue that process so you can get that clear slate of health.
Exactly. So Joyce, the whole point of why you've been kind enough to invite me here today is to empower women with the facts.
Yes.
So if you get the letter that says you have dense breasts, say, okay, there's something I know I can do to address that. It doesn't mean you have a higher incidence of breast cancer. It just means that your breasts look like a snowstorm. Ultrasounds don't hurt.
Okay.
They're not that expensive. And in this state of Connecticut, as well as 20 other states, your insurance company has to pay for that ultrasound.
And that's a wonderful thing when the insurance companies have to cover it. So listeners, if you're just tuning in, I've got Dr. Z in the air chair. We're continuing this conversation on breast cancer and breast cancer awareness. Now, Dr. Z is here to answer all the questions, and I've got some for her. So another question for you, lifestyle.
Yes.
How does that affect cancer, or does it affect the chance of you getting cancer?
It does. And so there's some real concrete science. If you're physically active 4 hours a week, now that could be raking leaves. We don't want to think about that. We don't want to think about shoveling snow. But it could be something as simple as vacuuming or walking, going to the gym. 4 hours a week can decrease your risk of breast cancer by 37%. Cut it by over a third.
Okay.
And you know, exercising is good for other reasons too.
Sure.
Our hearts, our soul, our bones. Go out with a friend. Take a walk. Number two, keeping alcohol intake less than 3 to 6 alcoholic beverages a week. In other words, there's studies that show that regardless of your age or ethnicity, if you have more than 3 to 6 alcoholic beverages a week, it increases the chance you're going to get breast cancer. And the third issue is obesity in postmenopausal women.
Okay.
So, let me say, as a postmenopausal woman, it's hard to lose weight. But we know that if we have more stores of fat when we're postmenopausal, that fat harbors an enzyme that can increase our estrogen levels, and that can increase our risk.
Okay, so those are important factors to know. And now, as we're continuing this conversation about breast cancer, whether it's obesity, lack of exercise, is it necessarily true if someone in your family had cancer that you're prone to possibly get it as well?
Yes, certainly if someone on your mother's side has had breast and or ovarian cancer.
Okay.
If you have multiple family members with all sorts of cancers, colon cancer, pancreatic cancer, either on your mother's side or your father's side, it's a risk. But there's an important fact, Joyce, and I think this is what you're driving at. 70% of women who have breast cancer have no family history. So you're right. Women who have a family history of breast, ovarian, or lots of cancers that are increased risk, but no woman should think, if she finds a lump and she says, well, nobody in my family's had breast cancer, she should not think that she's immune, because most women with breast cancer have no family members.
Isn't that something? Oh, my goodness. Okay. Well, that's good to know. And now, as we're continuing this conversation about breast cancer, how about genetic testing?
Yes.
And in the whole process of that, I know there's the, BRCA1?
Yes.
And when should you think about having genetic testing, particularly if you have a daughter or you're a mom and you have some concerns about this?
Yes. Well, the good news is the National Cancer Institute has set guidelines for who should have the testing. So BRCA1 and BRCA2 are actually mutations in two genes. We always think of it as the Angelina Jolie gene.
Yes.
And she did a lot for us because she heightened awareness, not just about cancer and breast cancer, but all of our health, looking at our family history. So it's only a small number of women who have breast cancer who have those mutations. But the flip side is, if you have a strong family history of breast and or ovarian, and now we're discovering multiple family members, as I mentioned earlier, with thyroid or pancreatic cancer, there may be a role for that. If you have breast cancer at a certain age, so any woman under 45 who develops breast cancer, regardless of her family history, should have a discussion with a genetic counselor. There are master's degree genetic counselors that can plot out your family history of cancers, look at your insurance coverage. Any woman under 45 or 50 with breast cancer should be considered. Having said that, only 5% will carry the gene mutations, but it's important to know. Any woman under 60 with a certain kind of cancer called a triple negative.
Okay.
Now, triple negative cancers occur more frequently in women of African descent. And we can talk about that more if you like.
Sure.
But the specifics are for any woman or man who has a family history of a lot of members with cancer, they should ask their doctor, could I benefit from genetic counseling?
Okay.
A good example, and I'm going to share this, that I had colon cancer in 2006.
Okay.
I'm happy to say I'm alive and well.
God is
I was
good.
treated.
Yes,
God is
yes,
good.
yes.
I was treated at St. Francis, but because I have a son, I had genetic counseling myself. So the genetic counseling isn't just about the implications for the person with the cancer or being tested, but as you said, our offspring and our siblings.
Yeah, just give them a peace of mind as well.
Yes.
As well. Now, you mentioned triple negative in African American women. Talk a little bit more about that.
So let me back up and say, what does that triple negative mean? So in breast cancers, we look at something called receptors on the surface of a tumor. And I want you to think of a receptor like an ignition. So in your car, you have an ignition. You put a key in, and the key turns the cells on. Some tumors have receptors, we'll use the term ignitions, on their surface that the estrogen in our body functions to turn the cells on. So that's called estrogen receptor positive.
Okay.
Some tumors have receptors for progesterone in our body. And then a third characteristic on the surface of a cancer cell, a breast cancer cell, could be something called HER2. So a triple negative tumor means there are no receptors for estrogen, no receptors for progesterone, and no HER2 genes on the surface. Well, why is that important is those three characteristics, the receptors or the HER2, are targets for treatment. So if your cancer has an estrogen receptor, there are drugs that can be given that block those receptors and turn those cells off, just like turning an ignition
to aggressively attack those.
Exactly, and target them.
Okay.
So that if a patient has breast cancer, she has the cancer removed, but then if the tumor's over 5 millimeters, doesn't have to be a huge tumor, she should be on an anti-estrogen medication that can block, even if one little cell is hiding somewhere, can turn those cells off.
Now, visually, 5 millimeters, what size are we talking here?
Well, if we think of an inch, that's 25 millimeters. So we're saying a fifth of that. So if you can visualize, an inch is 25 millimeters. Any tumor over 5 millimeters.
It's almost as small as a dime.
Oh, much smaller. Much smaller, yes. Like the eraser on a pencil.
Okay, okay.
So triple negative means a patient's cancer doesn't have a target for specific treatments. And therefore, if you don't have a targeted treatment, you have to use a treatment that's broader to treat it.
So now, in talking about that, and if you're just tuning in, listeners, we are continuing this conversation about breast cancer and breast cancer awareness. And I have Dr. Christine Zarfos in the air chair hanging out with me. And so we're specifically talking about breast cancer and African American women and triple negative diagnosis. Now, one of the things I know, or I've heard Dr. Z, is that just in trying to identify treatments for women of African descent, one of the challenges is when certain drugs don't work, about looking into clinical trials.
Yes.
And wanting to have more African American women participate in clinical trials, specifically so that we can identify drugs that are more aggressive for our care. Is that?
Absolutely. So I once was on a committee called Patient Advocacy Committee of a group called NRG. Okay. It's not important what the letters stand for. It's research on breast cancer, radiation treatment research, and ovarian cancer. And our patient advocacy group was worked on this for over a decade. How can we make women of African descent feel comfortable? In other words, trust when they come into a clinical trial. Yeah. First of all, the term clinical trial sounds toxic. Clinical trial. Yeah. And to understand that they're not guinea pigs, because we know about Tuskegee.
Yes.
Right?
Yes.
And so we can't ignore that. So trying to engage women, so that we have more information to help the next set of women or the next generation of women. I do want to say one other thing about triple negatives, though. It's been frustrating that we haven't had targets, but just this past Sunday, so it's timely you should ask me this. There was an article in the New York Times, and any of you can look it up, about this new research based on a clinical trial that looked at women, not just African American women, but white women who had triple negative tumors, and there is some hope with the new medication. So, I want to share some good news, some hope, and that article again was in the New York Times, and it's exciting for me as a surgeon because my surgical piece of their care is only one tiny part. But to be able to give women hope and realistic hope that even if you have a triple negative tumor, there are new drugs, but it required women to participate in the clinical research. Yes.
Now, Dr. Z, you're hanging out in the air chair, and one of the things that you're known for here in Connecticut is putting a hold on what's called this drive-through mastectomy. Talk a little bit about that, and thank you for that.
Well, thank you. Thank the women who trusted me. So I've been in practice for not quite 10 years, and this was in 1996, and the standard of care in Connecticut was that women who had their breasts removed, a mastectomy, had an average of 2 to 4 days in the hospital. That wasn't my patient. That was Connecticut hospital statistics. And boom, one day, 2 insurance companies said women have to go home the same day.
Wow.
And so I found this out Mother's Day weekend, actually 1996, ahead of time before it really hit us. I surveyed all the patients I'd taken care of. Now, surgeons don't know how to write surveys, but I sent a survey out. My patients replied with pages and pages of letters attached to the surveys, angry.
Sure.
How could you trivialize losing a breast, having draining bloody fluid? This is being frightened. So when it rolled out in August, and it was a wonderful African American woman I was taking care of in Middletown who trusted me. She and her husband, wonderful people who were willing to talk to the press about their insurance company was not going to allow them for her to be in the hospital. And she was young, she was prone to nausea. If anybody should have been in the hospital, she was. And we did win for that one night, and she and her husband went all the way to Washington for guests of Hillary Clinton to speak out on this issue. So I was just the voice of the women. I was nothing more than a conduit that people all around the country then would know that this little insidious thing was starting in Connecticut, and that the people of Connecticut were not going to stand. I mean, people. Breast cancer is a family disease. They weren't going to stand back and say, you're not going to just throw us out of the hospital.
Well, I say, look, you're the big kahuna in the air chair today, and thank you. Thank you for that, and
You're
thank you
welcome.
for taking a stand on it. So, listeners, if you're just tuning in, I've got Dr. Z in the air chair, and we're talking about breast cancer and breast cancer awareness. And so, Dr. Z, as we continue this conversation, there could be someone out there right now that just heard the news that they have cancer, that ugly C word. And so, as we continue this positive conversation, what are some of the first things you tell your patients when they hear something like that? Is this a death sentence? Is to know that there's hope? What are your words as it relates to this?
Well, what I do is I share what 30 years of women have taught me women want to hear. Again, I'm going to use the word conduit again. Women have taught me we have to take it one step at a time. We have to take a look at what this issue is. We can't fast forward. One step at a time. Certain tests, taking a look at it, and always giving realistic hope. The great thing, knowing women for 30 years, is that I've seen women go through so much. Just today, I heard of a patient who was diagnosed in 2003, and her cancer came back in 2016. But she's alive and well on the wonderful medications. I think this other number will help. In 1996, when I was talking to the public about the other issue, the statistic was 1.6 million women were alive in America with breast cancer. Today, it's over 3 million.
Wow.
That means that women with breast cancer are thriving. They're living. Yes, we have to have treatments. Yes, the cancers can come back. But again, it's like diabetes. You might have to take a pill for your diabetes and maybe then take insulin, but we have to look at breast cancer when it recurs as a chronic disease, and there's so many more medications, even now for triple negative, as I said.
Yes.
And we have to look at it that way. We can't look at it as a death sentence, which it was when I graduated from medical school almost 4 decades ago.
So there's been great progress.
Yes. Early detection, which I know you want to talk about.
Yes.
Early detection, and then the medications and the treatments. And the support. The support for side effects, the support for swelling in the arm. All sorts of advances about maintaining a woman's dignity and her quality of life as she goes through this process. The other thing I like to say that patients have taught me is we have to look at any cancer that we might have, regardless of sex or type. It's one chapter in your life.
Yes.
It's one chapter, and you use all the resources you have, your friends, your family, your faith, your spirituality, to help you through that chapter, understanding that our lives are books, and there's some good chapters and some chapters we wouldn't choose, and there's some fabulous chapters, and that the diagnosis of cancer is one chapter. You're going to get through it. You'll be a different person on the other end, but there is hope.
Yes, yes. Dr. Z hanging out in the air chair. I want to thank you for that. Now, is there anything that I did not ask you that I should have asked you that you would like to share with our listeners?
Well, I just think it's important to look at, I want young women, regardless of ethnicity, if you have a lump, go see your doctor. You may be too young for a mammogram, maybe not, or an ultrasound. If you don't get an answer that you want, go see another doctor. But if there is a lump in your breast, it has to be evaluated. So often I will see patients, and I see patients now as young as 22 or 23 with breast cancer. Not commonly, but they'd say, well, I went to my doctor, patients who are diagnosed with cancer, and he or she said, you're too young to have cancer. No, go get it checked out, particularly if you're African American. On the other end, the highest incidence of breast cancer are women in their 70s and 80s.
Really?
So let's not forget our mothers, our grandmothers, our aunties. And there is a push. The U.S. Preventive Task Force says no mammograms over 72. But if the highest incidence is in their 70s and 80s, you know, and there are a lot of feisty women out there in their 70s and 80s and 90s. My attitude is get your mammogram. If you have cancer, tiny cancer, you can take it out with an outpatient procedure, maybe just some Novocaine. Don't let it grow so that then you're 92 and have other health issues, and it's a bigger threat to your dignity and your quality of life.
There it is. I want to thank you so much for coming in and hanging out in the air chair. Listeners, if you're just tuning in, I've got Dr. Z, Christine Zarfos, hanging out in the air chair. Would you like to share any number or information about yourself so that if listeners do have a question or they want to follow up with care with you?
Sure. Well, Middlesex Health system has now created the Comprehensive Breast Center. It's at 540 Saybrook Road in Middletown, Connecticut, and also in Westbrook, where the new cancer center was built a year ago. The number is 860-358-2850. There are 3 of us there, 3 surgeons, Dr. Andrea Malon, Dr. Chachi Wang, and myself. We are breast surgeons, but you know, we like helping women not need surgery. And so we have a risk surveillance program where, what does that mean? It just means if you've had a family history of breast cancer, or you carry the gene mutation, or if you had a pre-malignant biopsy, because sometimes we as women have biopsies that aren't cancer, but they're pre-cancer. We're glad to see women in this program. We order their mammograms or MRIs or whatever is of value for them. We help women be proactive in their own care.
Yes, empowering women.
Yes.
All right, so we got to jump into some more music.
Yes.
I got you in the air chair, Dr. Z, and so who's on your playlist? Who are we going to roll out to?
Aretha Franklin and R-E-S-P-E-C-T, because that's what this talk is about. Right? We respect women.
There it is on 89.9. Thank you.
Thank you.
It's Qute-FM.